So here we go. So just to go back to our kickoff call and just do a little bit of a recap. So obviously the purpose of having these convenings is to talk with our folks who are doing the work. So they're doing the work with whether it's at a health system level or whether it's at a federally qualified healthcare center level. And it's really understanding what types of information folks are collecting for social health information and SOGI data. How are they collecting it? How are they storing it? And then what are they doing with it? And so we really jumped off the convening with the kickoff, knowing that today we'd be jumping into a little bit more granular detail and talking about the different social health data collection methods. So for today's session, just doing a little bit of housekeeping. This session is designed to really be a conversation. So there have been a handful of questions that we have given to our presenters here on the call today ahead of time in different areas, whether it's FGOH or whether it's SOGI. And so our hope is, I have the questions, we're going to sort of jump off and start into the conversation, but really this is meant to be a very organic conversation. So we certainly want folks to, I'll present a topic area to discuss and talk about, and we're really just going to let the conversation happen as it does. So for our presenters, certainly feel free to jump in. If folks are a little bit stuck, then certainly I can help to keep the conversation going too as well. But certainly we would like this to be as organic as possible. We have muted the attendees to prevent any background noise or disruption to our presenters. Attendees have access to both the meeting chat and the QA functions. So the chat is to be used to provide comments, feedback or requests for follow-ups. The QA functionality is to be used to propose specific questions to either HealthInfoNet and or the presenters. We're going to try to keep sort of a parking lot of questions. And really that's just to help, we only have 2 hours today. I think we're going to fill up that 2 hours and might not even have time to talk about other certain things too. So with that being said, if there are particular questions that come up in the chat or in the QA or in conversation, we may just have you parking lot them for various reasons. Either it is driving towards maybe an area of a deeper dive that's coming up in the future, and we can, make note of that and discuss it at the future deep dive. Or there might be some other necessary follow-up that we can do outside of the convenings to follow up with folks. So definitely keep that in mind, and it's not meant to be a rude thing, but just we're trying to keep the conversation to the specific topic area today. Attendees may be asked questions to share their organization's experience with social health and or SOGI through poll questions. So we encourage participation with that, but just know that the polls are optional. And all right, so just to refocus our session overview here to think about the different objectives and purpose. So we're here to discuss how HIE participants are collecting social health and or SOGI information with internal clinical workflows that they already have established, and or something else I want folks to think about is if you've also tried something and maybe it didn't work as planned, or you had to pivot and move to something else, that's also important to think about. With the learning objectives on how healthcare providers throughout the state are collecting this information, whether it's social health and or SOGI, identify specific tools or resources that are used by our healthcare providers to collect this information, and to understand the stigma, challenges, and or consent options and challenges associated with collecting this information as well. As I mentioned, we have these wonderful attendee presenters here from, as I mentioned, 3 of the health systems throughout the state: Northern Light Health, Maine General Health, and Maine Health. And then we have 3 of the FQHCs, Nassau Healthcare, PCHC, and Greater Portland Health. that are our presenters here today. So thank you so much. For the sake of time, I'm not going to ask everyone to go around and do introductions, but maybe as our presenters here on the call, whether they're asked a particular question or they want to make a comment and you're taking yourself off mute for the first time, if you just want to introduce yourself and your role at your organization, I think that would just be helpful to our other attendees. And with that said, I will take the screen share off so we can all see each other through the magical powers of Zoom here. And start with our first topic question that we have, which is how your organization is collecting social health data. So we're starting with a social health focus first. I should say that, so my apologies. So for the first half of the conversation, we'd like to focus on social health, and then what we'll do is move into SOGI data during the second half of our conversation. So as presenters, just want to keep that in mind. We're going to save special space for that as well. So this is with a social health focus and lens. So how are you collecting the social health information? So whether it's regarding food insecurity, housing instability or quality, or any transportation issues, needs, access, just as a few examples. So how is that information being collected during your patient encounters? And so to jump things off, or kick things off, I should say, I was hoping that Megan from NASAN, my CCAC, might be willing to start the conversation first, if you don't mind.
Sure. Yeah. Good afternoon, everyone. Megan Arsberger with NASAN Healthcare and York County Community Action. So we use the Prepare tool to assess for social determinants of health. Our patient panel fills that out annually. We try to assess our entire patient panel annually using that tool. And they will fill it out themselves. And we have our medical assistants, dental assistants, and behavioral health providers. So we utilize this information across all three of those areas. And we will have them enter that information into our medical record for our providers to then review that information during the encounter with the patient as they're meeting with that patient. And then I don't want to jump too far ahead, but our providers will engage in a conversation with the patient regarding their responses to the Prepare tool, and then they will actually determine if they're going to diagnose the patient with that social need, and using the ICD-10 codes, we will diagnose along those lines and then try to address that social need through a referral process. So Marty, do you want to add anything to what I just shared?
No, I think you hit it. The one detail I'd add is our medical record system is next gen. We use that for practice management in our medical record system, and NextGen actually developed a template that allows for collecting the Prepare tool data and actually add the responses to structured fields that we can query against. So we're able to do some population health work with this information, as well as to run reports showing folks with the actual diagnosis. When the diagnosis is made, it's actually included in the super bill for that visit, and the diagnosis is added to the problem list for providers to address in future visits. As far as the treatment is concerned, there's a range. If a patient is interested in addressing things like food insecurity or housing instability, with a case manager, we have the ability to have an actual formal referral to case manager elsewhere in the agency. Sometimes folks are just interested in some resources, sure, or just sometimes it's just a matter of acknowledging that the problem is there and this is not a good time to try to address it. So
makes sense. I know, Megan, you said so it typically happens at once a year. Are there any other time? And maybe it sounds like, Marty, what you were saying is that things can be addressed though outside of that if the provider sees that that was a need in the past.
Yes.
Okay, great. Excellent. All right, I guess to keep the conversation going, my next group of folks to hear from that I'm interested in might be Emily and Mia from Northern Lights. If maybe you want to speak to it from a health system perspective.
Definitely. Good afternoon, everybody. My name is Emily Tolman. I'm the Director of Health Equity and Access. And Mia is my counterpart. I'll let her introduce herself.
Good morning or good afternoon. I'm Mia Dubois. I'm the AVP of Patient Experience here at Northern Light.
Great. So we actually took this from a health system approach, as Nicole had stated. So I would say, just to give a little background, since about 2016, we were heavily concentrating on food insecurity, and we were just asking the two food insecurity questions and not the whole assessment at that time. And then as we launched into 2018, we all became one unified health record. So that really helped us be able to start to think about the process of how we can standardize this across the system. And so we actually adapted the CMS SDOH tool and the Prepare tool. So the Prepare tool is a standard of Cerner, which is the EHR that we're currently on. But when assessing that, we noticed it was over 21 questions, and we were really trying to limit the amount of questions to make it efficient and more timely in that our patients and our providers and care teams would ask this. So we trimmed it down to about 11 questions. The 11 questions that address food insecurity, housing, utility needs, childcare needs, loneliness, and then safety. So those are the categories that we're currently looking at. And so we had the opportunity, a couple of my colleagues were project team leads on a Pfizer IHI grant, where we were able to look at 5 primary care practices as kind of an early adopters to look at completing all of the 11 questions. And so we did that over the past 18 months or so. We started out with about a 1% baseline full completion of the SDOH. It launched in May of 21. But we noticed that as with launching it, it didn't really take off. So this next step was we did this pilot, and we were able to go from 1% to 12% completed in that time period of about a year. Also, another thing to note is that they're really good at asking the food insecurity questions because we've been doing it since 2016. So I would say partial screens are around 64% across the system. So we're just trying to get that moved towards a full screening moving forward. Another thing that we have too that pulls over the social determinants of health information is what we call HealthInfoNet, which is a data platform that's built behind Cerner. And so it's been able to pull over demographics, it pulls over conditions, medical conditions, number of medications somebody's on, and all the SDOH questions, and is able to kind of look at it from a risk perspective score. So we call it the Social Vulnerability Index. And so we're able to do this at a community level and down to a neighborhood level. So that was kind of the first phase. So we're able to go in, look at a county, look at a neighborhood level, which is usually about 400 to 500 houses in a neighborhood. And it will tell us, you know, these ones are red in this demographic. It talks about SOGI and real data. So we're just starting to try to kick off using that. Our community care teams and care management have been the early adopters of using this tool as well. So it embeds and pulls all that information through. The next phase is that we'll be able to get down to a patient level and have a risk score for the patient. And so that will populate in the medical record too as well. And so our screening is done annually at a minimum. It's usually done by our MAs on an outpatient basis, and also from a nursing perspective, usually nursing on an inpatient basis. And then we've also, as we're doing this, one thing that we learned is that Acadia, our behavioral health hospital, this information was not crossing over into our full database because it was protected, as we all know that information is. So we've been able to work with them and our system IS team to be able to pull that information over. So as we refer to as breaking the glass and pulling some of that information over. So we're currently working on a full system database for the whole entire system. So that's kind of our next phase so that we can pull this information down to the patient level. And along with that risk stratification, it includes other third-party vendors, platforms such as US Data, Development of Housing and Urban Development, the CDC, Environmental Protection Agency. So it looks at all those risk factors amongst the community that surrounds them. So we're just kind of in the beginning phases, I would say, of utilizing this. And then the next step is once we get that patient level data to really kind of spearhead it and spread it out amongst our whole entire member organizations. And then just one more thing I wanted to add to is we do have some community or navigators across our system. They're not consistent across our system, but we do have a really robust one. For instance, an example at Inland, and I think Bridget might be on the phone today. So often, sometimes she receives referrals. We have the ability where we have findhelp.org, which is now integrated within our health record. So if we do get a positive response, then they can utilize this as a tool to refer people, to schedule people. And so that's kind of where we're at this moment. I'm happy to answer any questions. I'll look in the chat.
The only other piece I'll add is we've done a lot of work over this past 6 months with enhancing our digital experience and adding new digital tools for self-scheduling and self-registration. And so as we're adding those tools, we're constantly thinking about how can we incorporate in this information to be captured via that online registration as well. So that's another exciting piece, that those conversations are coming up more and more frequently, which is always a really great sign when people are asking, what about this? How can we add this in? Which is exciting as well.
That's really great. I know that was one of the questions in the chat, I think, was making it available to patients themselves, being able to access it. I think now that folks are able to view some of their own patient information online now, right? So that's great. Go ahead,
So
Emily.
we have that with the SOGI data, but the SDOH data that's coming down our platform, which is called Tonic. So that's soon to be. So hopefully, as we know, individuals most likely like to answer those questions prior to a visit or in their own setting and things of that nature. So that's coming down the pike as well.
Excellent. That's great. Any other, and I should have paused for Megan and Marty. So any questions for NASAN or Northern Light Health from any of the presenters before maybe I call on another organization to share?
I have a question for NASAN. For NextGen, are you on 6.2021 for the year? Have you upgraded yet?
No, no. Later this year is the plan. Okay. We're also added. We've dropped the NextGen patient portal system, and we're adding IntelliCare or something, which will be a lot more versatile in terms of being able to collect collect survey information through the portal.
Great question.
Cool. I have 2 questions from the chat.
Yeah.
So starting with one that Megan answered, which is great. And Megan, maybe you can just summarize verbally as well, and then I'd be interested to hear from Emily as well from Northern Lights perspective. So the question was, when you screen, right, you have screeners, you have diagnoses, you have interventions, you have goals. And what's the most important one when you're trying to piece together somebody's risk or need? And Megan, it looks like you're thinking the diagnosis and the intervention is where NASAN is focusing your energy. Do you want to speak to that quickly before maybe we get Emily's thoughts as well?
Yeah, I mean, we definitely started with screening as a starting point, which obviously makes sense, right? To have a better understanding of the needs and to even practice those workflows, to be honest, as well, so that we, implementation of the Prepare tool itself to screen patients. But for us, it's always been really important that we move beyond screening. And so that's why I answered to say, I think it's just really important that we don't get stuck on screening alone, because for us at NASAN, we really wanted to move to codifying what we were seeing with our patients, because like the social elements greatly impact their health and well-being. And so we want to be able to document that and then obviously provide intervention to try to address those things so that we actually can be improving health for those individuals. And so for us, it was really important to move beyond screening. And we really have been trying hard to develop methods to, like I said, codify through like a diagnosis, but then also trying to build some systems around the social interventions themselves so that we have some standardization on those interventions as well. And so there's still a lot of work being done there, but just wanted to recognize that for us, it was really important to try to have really that whole entire system documented so that we really can be improving well-being for people that we are working with.
Great. Thanks, Megan. Emily, any additional thoughts?
Yeah, I think one thing that we've noted too is actually looking and analyzing the data. So what we've noticed from our data is one of the most popular responses or higher rated responses is loneliness. And so as a system now, we're looking at what are some interventions that can be solely focused on this. And so that's kind of the next step that we're taking.
Yeah. Wow. I think that kind of speaks just to where we are, right, in the state of the world, and how people are feeling sort of in that post-COVID phase of life that is all new for all of us. Chad, were there any additional?
Maybe just one more before you go on, Nicole,
Yeah.
and this one would be for Emily. When you were, and the question from Susan Whitaker is, when you refer to the patient risk score, do you mean the overall risk score, including medical conditions, or do you generate a special SDOH risk score?
So the risk score is actually all of those combined. So it's what we receive from the third-party platforms, what we receive from SDOH, and it also looks at chronic conditions, number of medications, and it will create an actual patient risk score. So that's the next phase. So right now that score is at a community level or county level. And so that's what we can see at this point. So how we utilize that is, for instance, if some of our care management teams, say in Hancock County, they have some openings to be able to take on new clients or patients, they will run that list to see, who has a higher priority and try to help manage and prioritize those patients.
That's great. Excellent. Thanks, Emily. And okay, if I had to pick my next group, Wendy, I don't know if you and your team from Maine General might like to touch upon what you might currently be doing, or what your maybe future plans in doing that.
Sure, happy to do that. Thank you. I'm Wendy Jorgensen. I'm the Director of Population Health here at Maine General, and I certainly have a team surrounding me today, so I encourage them to jump in if I need any help with questions or whatever. We have our team that are directly related to some of the work in the practices and our quality team. So we have a good crew. This work is a little newer to us. I think, like Northern Light, we had experience in the hunger vital signs and sort of screening for food insecurity. We had some strong processes around that, but sort of a more global screening for social needs is something that we're still in the implementation process of. We started back in July working with a paper form. We are using the Accountable Health Communities, Health-Related Social Needs form, and we use the 10 core questions plus 2 of the additional questions around family and community support. Again, suspecting that social isolation is a huge need. So it sounds like our neighbors are finding that to be the case. So I think it'll be good to see some of that data. So at this point, where we are is our primary care practices are being asked to screen patients annually. We have sort of identified an annual care visit as sort of the primary time where the screening might be done, although it could be done at other visit types. And we're asking the patients to fill out a paper form, when they check in for an appointment. And then the process that we're working through is building it into our EMR so that our medical assistants at this point can transcribe that data so that we have it in structured fields, and ultimately we'll be able to run some reports and sort of understand where the needs are in our patient population. But for now, our process is really confined to the paper product as we're building out the EMR tool. And, really it's a matter of identifying the patients that screen positive and then making sure that there's some supports provided to them. Each practice is handling this a little bit differently, but at a minimum, we do still have like a food resource guide and emergency food bags for the patients who screen positive for food insecurity. For some of the other issues, we did, our team of social workers created a resource guide, which we give to patients if they screen positive in any of the other areas. And that may also go hand in hand with either a warm handoff or a referral to one of our practice social workers. And so that decision sort of made, by practice, or, the clinicians certainly reach out to the social worker, depending on, their assessment. So that's kind of where we're at now, like I said, early in the process, but it's great to hear sort of what folks are doing and be able to absorb all these, great practices. And, I love the idea of getting to a point where you could have a risk score that incorporates some of these things. So that's obviously way down the road for us at this point.
Yeah, no, I mean, and this was really too, I think, a lot of what I know we've talked with you all as presenters about, but folks that are on the call, really, this was meant to be a way for folks that could share ideas and to kind of talk about where they're at, maybe where they want to go, and to be able to have that dialogue with each other. So I think we all know everybody is at a different place. It's a hard thing when you kind of try to conceptualize, to think about all the different areas of social health that you would want to intervene on in some way, shape, or form, but to try to put it into a process and operationalize it can be a whole other thing. So I think that's definitely great. I think everybody on the call would agree with obviously the analytics side of things and being able to take in all of this and help clinicians and providers move forward with the data. So I certainly appreciate that, Wendy. So thank you. Questions for Wendy and the Maine general team before starting small, thinking big? Yes, very true. Very true. I love that. Great. Okay, I will pick on maybe the folks at Greater Portland Health next to maybe share how they're collecting the social health data.
Hi, everyone. My name is Holly Glidden. I am part of the NextGen team, actually, at Greater Portland Health. And I was asked to be part of the rollout for the Prepare tool. So we are using the Prepare tool, much like NASON. And the workflow will be for us is that it will be done at check-in as well, but we may be using our community health outreach workers to help with patients answering the questions. I would say Greater Portland Health probably has been doing some of this work informally already because we do have community health outreach workers. We just haven't been using a tool to answer all of the questions. And I think one of the reasons we went with the Prepare tool is because we are going to hand out a paper format and then input the information into NextGen. But one of the biggest challenges that Greater Portland Health has is our patient population and the languages. The Prepare tool can be printed in, I think it's like 25 languages. Of course, not the major one that we need, but but it does cover a lot of our patient population. So we struggle with dealing with our patient population, the language, sometimes the cultural issues around them answering the questions, as well as their immigration status as well, because it creates fear for some of our patients. So we are trying to work through that entire process to be able to do this. I like the thought of reducing the questions because there are a lot of them. So that's why I was asking the question about that. So I want to take that back. We do have the ability to do that with NextGen. We are going to do it annually as well. But we're kind of pushing back to NextGen a little bit because we would like that document to fire when it's due for the patient, so that we don't have to try to remember or document the date somewhere. So some of the work that I am doing is trying to get NextGen to perhaps change a few things. In the future, when we upgrade, we're going to go with NextGen's portal. So we'll be on the PXP, and we're going to put the questionnaire on the portal to hope to do it at a pre-registration type format. Because like I think it was said earlier, you know, some of these are very difficult questions and they don't want to be answering them in a doctor's office. So that's where we're at right now.
Great. Excellent. Any questions for Holly or Nicholas at Greater Portland Health? Definitely, I think that was a really good point. I think making around your patient population and making sure that all of these questions, and if you're giving them to them in paper form, are translatable, and that folks are able to answer them if there are any language barriers in place. So that's definitely a great point that sometimes I think we forget about. So thank you, Holly. Really appreciate that.
Holly, this is Marty. What languages could you use that you don't have access to?
Lingala.
Have you been in touch with anybody at NAC about that?
No.
National Association of Community Health Centers?
No, I haven't. So, but that's a good point. We could do that. But yes, that's one of our biggest population. Thankfully, we do have some employees that speak Lingala. However, they're not at every location. So, so that makes it a little challenging.
Yeah, definitely. Great. All right. If there's no other questions, I will pick on Misha and the folks at PCHC maybe to add anything additionally to what they're doing in their process for this as well.
You're muted.
Oh, Misha's microphone is not working. Okay, so Misha put in, I can probably go through and read this for people quickly. So Misha is the manager of social work at PCHC. PCHC's care and case management teams utilize the Prepare tool at intake for their respective programs. So that's BHH, CCT, CCM, et cetera. And annually from there, provider clinics are also starting to roll out the tool in pre-visit planning process. It's built into Athena, their EMR, and attached to an electronic annual assessment. We adapted the Prepare tool to include 9 questions on socio-demographic and socioeconomic characteristics, family and home safety, money and resources, around education level and employment, and so psychosocial assets, social and emotional health, as well as the cost of living and care they experience. Utilize the tool to currently assess individual needs and communicate back to the providers when referrals might be warranted from the information gathered. And Bilal might have more to add. Great.
Hi, thank you, Misha, for explaining that. I'm sorry, I didn't see that your microphone was not working, or else I would have helped you out. But yes, you did excellent. So those are the key points when it comes to definitely the social risk needs. We have a wonderful Prepare tool, and the care management team is always behind that, and we track that for a lot of reasons. When it comes to SOGI score numbers, that is, we have a patient information form, what we track on annual basis. Our patient service representatives, they collect that information on annual basis, and we try to update that. We are also trying to get SOGI numbers using our kiosk in future. We have kiosk at different sites, and we do kind of collect some demographics, but we haven't started collecting the SOGI numbers. And we are also talking about getting some SOGI or social need numbers from our patient portal. We recently have a new patient portal, what we have implemented, and more to come on that. But these are some quick updates, what we do. Yeah.
Awesome. Great. Thanks, Bilal. I think, that's one of the things I think that maybe we hadn't really thought about too at the team at HIN is thinking outside of the norm, right, of how you interact with folks. So I think obviously there is still a lot of that face-to-face, but there's also now, obviously because of COVID, there's telemedicine and telehealth. And so I think one of the really good things that I think I'm taking away that you all are mentioning is that even just the thought of putting some of these questions in a patient portal and having it be more of that self-serve functionality for folks is also a really great consideration. I think, like I said, we're very used to our typical means, right? And when you think about what a typical office visit looks like, and I know I have to start thinking outside of the box, that's things are moving in a different direction, and you kind of have to adapt with some of those needs, really. So that's a great point. Is there any questions, Chad? Anything that's brought up before we maybe do a polling question, or anything else that we want to emphasize with this topic area?
I think we can go ahead with the poll before you continue with some of your other questions.
Really quickly, Bilal, could you talk a little bit about the kiosks which you utilize?
Sure, absolutely. So recently we have started working with ClearWave. So that's our vendor that we have different kiosks, and that helps us in basically schedules. And when the patient are in the waiting room, we try to get their demographics or some information regarding some quality measures, but not all of that. But mostly it's about check-in and check-out. It helps our patients to utilize that and schedule their appointments for future. Yeah.
That's cool. I like that.
Yeah, and I'm sorry, I think I didn't introduce myself. I work as the Quality Improvement Director at PCHC. I'm sorry about that. Yeah.
Oh, that's okay. Thanks, Bilal. Appreciate it. All right. And I know I don't want to not include Anne and Brandy from Maine Health. I don't know, certainly if their focus is going to be more SOGI, but if you have things to add too, I don't want to leave you hanging there in the background. If you have anything to add, please feel free.
Hi, I'm Ann Du. I'm part of the clinical informatics team at Maine Med. I can just touch on some of the things at Maine Health that we're doing in terms of required screening for patients that are admitted. They'll do the nurse will do an alcohol, drug, and tobacco screening along with an admission screening. And then there's also some work being done with food insecurity being required for the nurse at Southern Maine Healthcare, and they would have some follow-up with social work being consulted. And one of the newer initiatives is diaper insecurity for our pediatric patients. So we're screening them for that and providing a social work consult as well.
That's great.
And I could just add, I'm Brandy. I run the gender clinic, so I'm an ambulatory provider, and for this is not an initiative I'm informed of what we're doing all throughout Maine Health, but there are 11 sort of screening tools that are included in the behavioral health tool package that we have in our EHR. And so I have access to these 11 screening tools, and I can look and see how some are used and some are not used. So I think we're gearing up towards an initiative to have them all completed here. It looks like this was added kind of more recently, so I think getting the tools in place where they can be used. But I haven't. My guess is that I'm not primary care, so my guess is that they're directed more towards primary care as opposed to specialty. But I do see those 11. Everybody kept saying 11. I'm like, I know what these 11 things are.
Yeah.
This is Holly. I can just kind of speak to that for Maine Health. I just had a recent visit at a Maine Health organization And they do ask the SDOH questions. It was on there. It's part of their pre-reg. It's on, actually was on there through the portal, through your My Chart.
Yep. Excellent. Great. Thanks, Holly. And thanks, Ann and Brandy. I appreciate that. Chad.
Yeah, before we go to the poll, there's maybe a relevant question to ask one or two organizations, which is how do differing federal, state, and/or community programmatic requirements may impact some of the social health data collection efforts and the priorities at your organizations? I don't know if folks may have examples that they could speak to there.
Yeah, federally qualified health centers have a bunch of things in common, and one is that we are required to collect, we have been forever required to collect information on our patients' financial picture, as well as things like SOGI data, housing status. So we've been collecting these data right along. And interestingly, when we began using the Prepare tool, we've started to see some inconsistencies. We understand that 18% of our patients are objectively homeless, according to the HRSA definitions, but in fact, 6% report that it's a problem as they go through the Prepare screening. So but to your point, Chad, yes, we have been obligated to collect a whole lot of data and report on it on an annual basis. We're in the throes of our UDS reporting right now, in fact.
And just to add on to that, I think it's a good thing now that there are regulations coming down the pipeline as well, because it shows how important this is. But just recently, they proposed a national patient safety goal around health equity. So we'll find out in July if that goes through, but usually it will. And so that's around, looking at quality and risk in regards to health equity. So moving down the pike, how do we do that? Do we make sure that we're asking questions at all RCAs, things of that nature? So I think it's good that these things are coming. Joint Commission as well has some more health equity data requirements as well. And so this may be a push for that data, but like you said, a lot of us are already doing this.
Great. Thanks, Emily. Any other thoughts, additions to that? I think those were really great points, both from the FQHC side and from the health system side. All right, let's go ahead, Chad. Actually, we're going to put up a poll.
All right, so this is for the attendees. So speakers, you're not going to take this one, but for attendees, the question is your organization currently collecting social health information, social risk factor or needs information during patient encounters? So we heard from our speakers, but want to hear from you all. And so we'll leave it up for a few more seconds. I can see how many of you have taken it, and then we'll close it and show the results. All right, we've got about half, so I'm going to end the poll and we can share the results back to folks. So 89% of you who answered are collecting in some form, 11% are not. So thanks for sharing that with us.
Great. All right, so moving on, I think that initial question really sort of answered a lot of other secondary type questions around how folks are collecting the information, how they're codifying it. But I think one of the things that is popping up in the chat a little bit, and one area that I kind of want to go to next, is sort of thinking about the stigma challenges that are presented. I know we kind of touched upon it a little bit around giving folks the ability to choose, right, the space and time to which they're sharing this data. So kind of talking about the ability of them to provide this information during a pre-visit or at home before their visit or on a patient portal. But I think what would just be interesting is if you've encountered any stigma challenges at your organizations, if you've been able to talk about it or come up with a way to plan on discussing with it, maybe through some staff education. But I guess just in general, how are you all finding ways to approach this challenge? And I won't call on anybody initially. Maybe I'll just give a minute and see if anybody wants to jump off mute and answer it. If not, I can pick on someone.
I can kick us off. This is Megan with NASAN. I would say this is kind of always be an issue that you're always going to be tackling regardless. However, for us, I think we mentioned how we use diagnoses as well as just in addition to just screening. And so there really is a conversation with the provider that's taking place. And so depending on what's going on with the patient, like it was kind of referenced in the question, the patient may feel more comfortable disclosing information with their provider, but then didn't say something on the prepare tool. It doesn't mean that the provider couldn't make a diagnosis, so the provider could still very much take action to support that patient. But I will share something that we are seeing and that we're learning from is that we will, on the social service side, receive those referrals from a provider. And clearly the patient has indicated, oh, I'm having, food insecurity or housing insecurity. And then they have a conversation on the social service side of things. And the social service, our case manager will conduct kind of further questions and assessment. And we actually will find out that the patient may have completely different needs that they didn't share, right, with the provider at all. And in fact, the thing that they were referred for is actually not really the thing that they want the most support around. And so we're really encountering that pretty frequently. And so we do try to address obviously what the situation, what the provider had diagnosed the patient with. However, it just speaks to this fact that oftentimes, they might feel more comfortable, even especially a case manager who's meeting with them in an ongoing fashion, they're going to learn a lot more about the additional social needs of that patient and build those relationships, which is a good thing, right? Like that's a good thing. And part of the point is we want to address all of those things. But it definitely gets back to the fact, like we were getting to that, that the patient probably isn't disclosing all of this information to their provider. And so I think it's something that we're going to continually learn from and continue to grow around. We have developed, I think, some very clear clinical guidelines around for our providers to use around like how do you have these discussions with patients, and we've built them out specifically: transportation, food, housing, and previous incarceration. So I think we're going to continue to hone in on that and like how we approach the conversations with patients. And we've just recently implemented monthly meetings between our providers and the case managers who are doing the social interventions, because we're realizing that there probably does need to be additional education for providers around how do you have these conversations and how do we think about this work. So those are some of the ways we're trying to address it. Marty, do you want to add to that?
Only that we really don't have any good way of measuring stigma, the impact of stigma on patients, how they decide things. We know, and objectively, there's that disparity between folks who report homelessness being a problem and folks who report they are objectively homeless. We anecdotally we work with families sometimes who meet eligibility criteria for Maine care, for example, but choose not to apply because they don't want to, it's they don't want charity or whatever the point is. So I'd be interested in knowing how have others have addressed both stigma empirically and how have you measured it? Thank you.
One thing to add that Northern Light is currently working on is we're doing a campaign. Many of you have probably seen How Are You campaign that we've been doing across our system. So we're going to tie that into why we ask. So why we ask these questions. So we're currently doing a video production right now for both internal and external stakeholders. And this will be live in March. And so it's really kind of a neat facet where we're asking, we're explaining an individual, and then, you're not just your diagnosis. So you're not just this. And then why we ask the other questions. So it's not, you're not here just because of your heart. You're here because of X, Y, and Z. And really kind of playing on that fact that social determinants and things of that nature are also part of your health and your healthcare. And so that will be coming out in March. So I'll definitely share that link with this group as it goes live as well. To hope, kind of get the community thinking, this is why we ask these questions. And it's going to be hard to measure. Like you said, you asked, how are we going to measure that? That's a great question. And I think that's something that we'll continue to think, how are we going to do that?
Yeah. I think it's an important consideration, right? As you think about sort of these tools and some of the things that I think about, and I feel like we heard, we had done work with the FQHCs around social health data a couple of years ago. And I think one of the things at that time that folks were struggling with was sort of a little bit of what Megan and Marty mentioned, like anecdotally, sometimes really some challenges for the providers at times, I feel like, to even ask some of the questions. When do you bring it up in conversation? Who are they comfortable with? When you think about folks enter a room and they're roomed by, a nurse or an MA, and they might not share certain things with that person, but they want to, talk with their provider who's doing the, the documentation, which I know we'll get into documentation in the deep dive number 2. And then for some providers, I think we heard that it was hard for them to even want to ask the questions because they weren't sure that they could provide resources on the other end. And so I know that too, like I'm jumping ahead as I even mentioned that we have, parking lot for a reason, but sort of looking towards those things, I think it's even now really important to kind of think about that in this first section here, is that that's a real thing. And that's, something I feel like puts, almost that barrier up because you don't, how far do you want to go into something with somebody? They've, how many times do they have to share their story with somebody? And especially if there is a system delivery model, right, that would put that person in touch with the right folks, right, if a referral is made. But how many times do they have to say something? Does that, create a problem or an issue or stigma or so on? And so I think there's a lot of things to think about just in merely gathering this data that are hard, that in the end, you want to be able to help people and provide them with the resources, but it's trying to get from like A to Z in a way that makes sense too. So yeah, I don't know if there's if that resonates with folks or if that is something to just being able to, I guess, find the balance in two, sometimes asking those questions face to face, sometimes, putting that prepare piece of paper in front of them too. And sometimes, what does that look like? Sometimes it is a great way to get the information. But if you're not having that dialogue to, like what Marty said, everybody's understanding of a prepare question could maybe be different. And maybe the real thing that's the priority to what Megan said is different, right? Like you ask a very, simple question or a scaled question, and really there's a lot that might be a part of that answer that could go myth or, misrepresented based upon what everybody's understanding of it is too. So I'm just kind of curious if folks run into that at all, or if that's something that you've all considered at your organizations.
I think it's a skill set to be able to ask these questions. And I think we do need to train people appropriately as best we can to ask these questions because they are extremely sensitive questions, and difficult to ask, even for myself. And I know about the questions. But when I first saw that on my chart, I'm like, if I hadn't have known, I would have said to myself, why are they asking me this? Like, what's the point? So I'd like what Emily was saying about the campaign, about why we ask. And I think as perhaps as organizations, we do need to have a little bit more work around that to help patients feel a little bit more comfortable. I also think we need to be really careful about setting expectations. If we're asking these questions, patients are going to expect, depending on how they answer it, that we're going to do something to help them. And if we can't, then, so I think it's a real skill set to be able to ask these types of questions.
I would just add it's a skill set, but it also, we also need to just value it and help our providers understand that housing is health, right? Childcare is health. And so trying to just change that mindset too, in addition to, the training itself.
Yeah, it's a really great point.
Yeah,
Well, there's oh, go ahead, Emily.
I was going to say, I always think, we ask questions about diabetes, we ask questions about hypertension. We need to get to the point where we're asking questions about social needs, that they're all equal.
Yeah.
Won't that be nice?
Right? Absolutely.
There's a question in the chat. So it veers a little bit away from stigma, but it's a good one in that it gets to the why are these things being asked question. And the question that's posed is, do organizations see the purpose of social health data collection more meaningful in the clinical encounters, so helping the patient is how I interpret that at the individual level, or to address some of the structural or community issues that are at play? I don't know if anybody has any thoughts about that they could share. Marty, I see you came off mute.
Well, yes and yes. I think before we can make the case in the public policy arena that we need to do better with our transportation system, and we need more affordable housing built like immediately, we need the data. We need to be able to say, X percent of our patient population would benefit greatly from this, and in fact their health outcomes would improve.
Yeah, absolutely. And I think those are the things that are so often overlooked. I think when you're so busy addressing you're addressing the chronic condition, or you're addressing the acute need, without realizing that there are other factors that are contributing to that. And quite frankly, it could be somebody's ability to have a ride to get, or have transportation to get somewhere, to get the care that they need. And that it's important, just like Emily just said, to have that be a part of the equation that folks are thinking about when you're not only just treating somebody solely for, a medical need. Others' thoughts?
Maybe another question that's in the chat here is, and this goes back maybe to stigma, perhaps, is, and maybe Holly, I don't know if you want to go off what you mentioned earlier, or if others want to chime in, but the question is, how do you deal with struggles with literacy of community members when it comes to providing them with written assessments to fill out? And Holly, you mentioned a language barrier. This seems similar in a way, so I don't know if you have any thoughts about that, or if others want to chime in.
I mean, we try to use that's cases where we try to use our community health outreach workers to help with as much of that as we can. It's a very real challenge, unfortunately. And, I don't think we are perfect with it. We do use a lot of interpreter services and that sort of stuff. We try for our language needs, we try to get as much stuff translated into as many languages as we can. But yeah, it's a big challenge.
Yeah, I can speak to this a little bit as well. We struggle with health literacy, and we have a group that's slowly trying to look at the literacy level of all of our consent forms and all of our documents, and it's a huge undertaking. There's lots of tools out there, but it's a very manual process to get this readable. We also try to interpret our documents into other languages, and we use Stratus for interpreter services, and through our contract we're able to give them anything and they will translate it into the language of choice, which is excellent. But again, it's labor intensive and you have to know the steps to take, but that's something that we're working on.
Great, thank you. Yeah, I mean, oftentimes I think we just assume folks, you know, if we hand them a piece of paper, they're going to be able to read it, and that's not always the case. So I think it's also something to think about, even when you're thinking about language, is reading level and what folks are able to see.
Yeah, I will say also, we have pretty robust patient and family advisory councils at all of our member organizations, and we leverage them as much as we possibly can. So I attend every one of those across our system. And so I'll bring different documents, new education, whatever it is, and just get that feedback from community members across the state to say, how does this look to you? Same thing with our patient portal. When we're doing new digital things, we show them the layout and say, what do you think? How does this language? Do you like the word digital or do you like this?
Yeah.
And so they have been a huge resource for us, and also starting up some focus groups surrounding some of the new initiatives to see how is it really going. And getting that real in-time direct feedback has been incredibly valuable.
Wow, that's excellent.
Nicole, I've been trying to find a thread to come back to this question in the Q&A chat, and I think Holly, you helped me get there. So you mentioned that Greater Portland Health uses community health workers for maybe overcoming some of the literacy and language barriers, and I guess a couple of questions. One is that an experience that other organizations have as well, using CHWs to do that sort of work? And then the subsequent question on top of it, getting to the question itself, is what's that workflow, and do those CHWs actually interact with social health risk screening tools that your organizations are using?
I guess I'll speak to speak to that. So for instance, Greater Portland Health has been holding what we've been calling some new Mainer clinics. And at those new Mainer clinics, we've had the we call them chows, there. And they're oftentimes the first person that the patient will meet with, and then they might meet with our financial aid counselors. And so it's kind of a group effort. The way that we are hoping to do it with SDOH is that the goal would have them kind of meet with the patient prior to the appointment. So the patient would come in a little bit earlier, and then they'd go over the questions with them, and then the questionnaire would be handed to the provider or the MA, which one of them, but the provider to review. Sometimes it's just a little bit easier when it's not a provider in a exam room. You know, so that's kind of the goal. I have, my hat, the chows are a very important part of the work that we do for just these reasons.
Yeah, there was a question that asked about how do you overcome patient reluctance to an MA, maybe somebody you don't have that type of relationship with, asking kind of these personal social questions. And it sounds like, Holly, from your organization's perspective, the CHWs are that source of familiarity and to personal connection, right?
Yeah, I think, that's the way we would like to be able to use it. But still, I'm sure we will be faced with the challenge of people not refusing to answer. And we can't make them answer. So it will just be what it is.
Yeah.
I have a question for the group. What age of the patient are you starting this at? There's been some questions within the organization about, well, what are we doing about our school-based health center population? Are we going to start at age 18, legal age in the state of Maine? So just curious of what other people are going to be doing.
So I can jump in and just tell you at Northern Light, we started with 18 years and older. It's written in our policy. But as this tool has gone live, our pediatrics offices are starting to utilize it. So it's growing fast. So our policy states 18, but like I said, PEDS is jumping on board and starting to utilize the tool as well.
So they're asking the parent, or?
Depending on the age.
Okay.
If they're 13 or older, they've been asking the patient themselves.
Okay, great. Thanks for the info.
You're welcome.
Yeah, we only screen adults, but as with Northern Light, if it comes up for younger people, we would certainly make a note and potentially a referral, potentially engage the parent.
Great. Thanks, Marty. Wendy, I see your hand up.
I was just going to add that at Maine General, we sort of developed a 12 and older form that, you know, is based on the CMS tool. And then we have for the 11 and younger patients, we sort of reworked the questions a little bit so that it's directed to the adult that accompanies the pediatric patient or the younger patient into the visit, but we're asking all ages.
And it does look like Misha wrote in the chat for PCHC, the pediatric program still uses the tools, but we coordinate with parent or guardian and they can decline if they want to. That's great. Excellent. All right, so we're at that time in the convening that we're going to change gears just a little bit from social health data and move over to SOGI data, or sexual orientation and gender identity information. So with that, to sort of lead off the conversation, Brandy Brown from the Gender Clinic at Maine Health is going to do a little bit of a PowerPoint, provide us a little bit of information, and that will sort of jump off our discussion.
Thanks for having me here. I feel like once I have the SOGI data all sorted out and, you know, we have that complete here, I'm probably going to go back and jump on the SDOH data collection. It's a really, really lovely past hour to hear the strategies everyone's using. So I'm just going to, I'm just buying time while I figure out how to share my screen here. So I just have a couple of slides. Wasn't sure I'd be able to come, so I was going to send something in. So I'm going to tell you just a little bit about the initiative we've had here at Maine Health. And then we're going to demo the actual tool that we're using for data collection, at which time I will critique the tool and hopefully give you some ideas of what not to do or to do if you have the ability to, or things to think about. So, and Andrew is with me with our informatics team to back me up and correct me as we go through. So we're both part of a group of folks. I would say we've been doing a grassroots effort. So this initiative with SOGI has been kind of grassroots and now up to system level. So for Maine Health, so we've kind of a myriad of approaches with the SOGI data collection. And I would put myself as the grassroots champion since 2017. Like SOGI, like we have to collect this data. I've had 3 different EHRs. I've had to work within. So Cerna, Meditech, and Epic is what our system is using now, system wide. But when I started here, there were 3 different systems that my patients might have charting in. So I'm really aware of each system is very different and challenging, and there's so many ways to work around things. So I was delighted when I found out there was a way to capture data in one space in our health record. And in 2018, we had a soft rollout of this tool added to our ambulatory EHR. And then in 2019, we added it to our inpatient EHR. And so now you can pull this tool up in any setting. It hasn't yet been mandatory. So right now it's just people opting in and deciding to complete this tool. We've done there was a go live training from the Epic side in 2018 and 2019 to just really push out and get folks using Epic. And as systems have different parts of our system have come on to our unified EHR. Epic training has occurred, or the training has occurred that included this tool. And then I have taken a clinical approach. So I'm a social worker. So I have gone and I've trained a few thousand people on using this tool, and that has been individual sessions with people. I'll go to someone's practice and teach them. I put it in didactics. I've done it in a couple of different grand rounds. So if I get in front of a group of people, I like to share this tool. And I think that's a piece I want to highlight, is the demonstration is much more valuable than giving folks tip sheets or showing them where they are. I feel like this is one of those things where people need to ask questions and really understand how do these words come out of my mouth when I'm communicating with someone, and it's not. I think that's the biggest barrier, is that comfort with the information. And in my understanding, there's really mixed data and mixed best practices on whether the patients should enter this data, such as with giving them an iPad. So we saw that at UCSF as a patient entered. Potentially that's the best way. And then we're seeing from Fenway that maybe having our registration collect the data might also be appropriate. So I'm a little bit of a champion on the clinical side, and having, for the complete data collection, having someone with a relationship with the person, although we should all be responsible. So we've tried a lot of different ways. This is what the actual tool looks like, and we are going to demo this in a minute. So don't feel like you have to read all of it. But that's what our smart form looks like in our Epic system. And we did get permission from Epic to share with this group today. So the initiative has been getting folks to fill this out. And I think it's important to know some of these fields do appear in registration. So our administrative folks can enter, such as gender identity, and some appear in our patient portal, which is my chart. So patients can enter some of this data. And some of it is only on this form. So there's kind of a few different places where some of the information can be put in. So like I said, I've been working on this, so 2018 and then 2019 inpatient. So we've had a lot of opportunity for this grassroots push to get people to use the form. And so just looking at how often is this filled out, we're seeing inpatient. So the last 6 months of last year, we saw everything's around sort of 17% of patients having this data filled out. So we just chose 6 fields of the form to really look at. So legal sex, pretty much 100% of folks have legal sex filled out on this is just Maine Med data. And then sex assigned at birth, gender identity, sexual orientation, a preferred name, which is actually a different field, but we feel like it should be part of this OG conversation, and then pronouns. And then we went to say, we don't, like I said, it's not mandatory for this to be filled out yet. So who actually filled this out in the hospital? Like, who were the people who did this? And we found that 74% I only looked at gender identity, just that one field, since it was accessible in all areas. And 74% of the patients who had filled this information, who had been hospitalized, had used the patient portal, whereas a quarter of folks coming into the hospital had mostly a nurse had filled out that information. And I think it's added into the nursing screening. And then I looked at the ambulatory side. So Maine Medical Centers, ambulatory side is Maine Medical Partners. So on the ambulatory side, for the same time period, we saw again, around just under 20% of folks had entered in this data. Which I feel like that's a great number for grassroots effort to get 17% of your patients. I mean, I feel like this has been just amazing to have gotten more and more people on board with voluntarily including this in their patient screening or demographics. And so for the ambulatory side, we did see again a lot of folks entering in the patient portal, but we also saw an increase in, it looks very small here because it says 1%, but it's 1% of 140,000. So we had a lot of physicians and residents and social workers and nurse practitioners and outpatient counselors who had also been including this information in. So, but obviously a big takeaway is if the patients are able to fill out are able to, if you give them the opportunity, they will, they're more likely maybe to fill this out before an appointment. So that's really promising. And then a couple of the takeaways here. I think real big challenge for us is that the pronoun field was built into the clinical tool and cannot be accessed in the administrative or the patient portal. And that has been a challenge since day one. And we know that Epic can't fix it. Like we know that we're not the only people with this problem, and we have gone back over and over, and it is something that can't, it's like in the foundation of the build and it can't be fixed. And I think they're really trying to figure out how to, I'm sure it can be fixed, but without kicking out other data or something. So I think they're really working on, I think they recognize that pronouns aren't necessarily a protected, like a clinical field. Another piece we've had challenges with is who really should own the form. And everyone I talk to is like, well, maybe this should be nursing, or this should be primary care, or this should be this person or that person. And so figuring out who owns the initial, to review the initial collection of this information. And we think potentially, it would be ideal if this happened at, we all had like convenient primary care appointments, and we all started our health care with preventative care. It'd be lovely to collect all of that, but there's so many places people enter, but it may or may not be appropriate when they're coming in for an emergency department admission to sit and go through this form first. So trying to really negotiate where's the best place, and having kind of a timeline. And then I think important, the patient portal is very successful. When we looked at the disciplines of who was putting the information in, especially in ambulatory, we did find a lot of shared ownership between different disciplines and types of staff. And I think that's really important. Like if whole teams can own this is valuable, then we're going to be more successful. The way this is built, we're able to utilize this for like the support tools that are in our EHR, such as the OB order set or different screenings, which is, really bringing it to the, like, what's the actual clinical value. For Maine Health, right now, Ann and I are both part of a group that's going to be working from February to October to develop a system-wide plan for rolling this out to our whole system as mandatory as part of our FY24 strategic plan for Maine Health. So we are looking at gathering more information from all of you and continuing to work on this. I think we're gonna demo the tool here, and then what I said will make more sense, I hope. And Ann's gonna pull that up.
Yeah, let me share my screen.
Thank you so much.
Sure. All right, so are you able to see my screen okay?
It's all black for me.
All black for you?
Yeah. Oh, there we go.
Oh,
it's the
awesome.
Test environment.
Yes.
Awesome.
Okay, so to access the screening, this is what Brandy was referring to. Clinicians can quickly access it just from selecting the gender.
Yeah.
And then I'll take them straight to the SOGI form where they can fill out this information. And one of the more common things that nursing really collects, which is my primary clinical group that I support, are the pronouns. So if there are certain pronouns that the patient uses, you can select them and they will display on the storyboard so everyone's aware and how to interact with the patient and what pronouns they use.
Yeah, I think just a few things I want to just share on this. A couple of challenges, or I guess I'll say one of the pro features of this, I feel like, is we're capturing legal sex, gender identity, and sex assigned at birth as 3 different fields. I'm not sure if everyone's doing that, but they can be 3 different answers. And I think that's really important that if we're going to capture one, we collect all 3. So I think that's very helpful. I love that we were able to make that shortcut so that any user can easily access it. I think that shortcut has made a huge difference in people using the tool. You'll see there's this little comment box next to the pronouns if you want to click on that. And so we made this comment, it's to the left. Yep. So we made this comment box because a lot of people use multiple pronouns. So if this person was they, he, you would just type in they/he, and then that when the screen refreshed would also show. So it gives you a chance to capture multiple pronouns, but also having the primary selected. I think that's really helpful when communicating with patients. We did have to make some changes for affirming language in our original field. So I think having community folks be involved and making sure if you're sharing, like the words are actually appropriate, because some of the language in the original form we just deleted. We were like, there's literally no way we're going to show this to a patient. Somebody dropped the ball, and that was corrected by Epic later. We added a surgical history. If we're going to talk about that, we added the surgical history. So it just jumps. There's a link that goes straight to the surgical history, so you're not going to this form to figure out surgical stuff. And this person, probably didn't have that history, but it just takes you to the medical history. So we're not trying to figure out surgery. And then I think the organ inventory has been really helpful, and that's where the screening, I think, is most useful if we can get an organ inventory. So then if you're doing a screening for cervical cancer based on people who have a cervix. And I think that's where OBGYN got really involved with, like, oh yeah, we're going to use this form, because then it helps with those automatic screenings. Some of my critiques are the, let's see, what were my critiques? One of my biggest challenges with this form, I guess, would be two challenges here. The sexuality field is, like, it's less useful for the patient. Like, it's really hard to convince patients why is it useful for us to have, like, for you to know if I'm gay, lesbian, bisexual, or other, like, what is the value of that? And I think the information is poorly captured, because and the other piece is making sure that providers know that is useless in terms of a sexual health screening, because I think a lot of providers are like, oh, we'll click lesbian and then we're going to screen this way, and it's just not accurate because it doesn't tell you what's happening with body parts and partners. So I think we've that's a bit of a challenge, I think, in terms of patient and provider education. The form, if you saw the gender identity, there's female and trans female, and I'm currently trying to fix that. It's really inappropriate for us to have female and then transgender female and then male and transgender male as gender identities. So they should be labeled cisgender female and cisgender male, transgender female and transgender male. And that's a big issue. We're trying to get some relabeling. So I feel like it's a very big issue, because you have to combine trans female and female together to get useful data. A lot of patients are going to not select transgender female if that's not their gender identity. So I think we either need to combine or better label. So I feel like that's a big challenge we're going to be solving in the next year. And then the other is in terms of gender identity, when someone has an intersex identity, that doesn't mean they have a DSD condition. So differences of sex development versus intersex, there's a big debate here and how we're going to use that information. So if a patient says I have I'm intersex, how do you really capture that while also retaining the accurate medical information? You're not going to say, well, that's not your identity, but also, like, how do we make sure we're also capturing if they have a DSD diagnosis, not based on just patient report in this. So those are my big things. I have been talking about this data collection for a long time, but I'm not a analyst or informatic person. Like I said, I lead the gender clinic supporting patients of, I think our patient panel right now is age 3 to 75. So I feel like a lot of patient input. And I think people are, in my clinic at least, are happy to see that there's some shifts happening in healthcare and that people even care, because a lot of people are very fearful of what if I'm in a car accident and I go to the emergency department, what's going to happen? I think that's a big question. What if I can't advocate for myself? How am I going to make sure, that this or that is happening appropriately and people aren't having weird conversations about me and I'm getting the right screenings and support. So I'll be quiet, but thanks for letting me jump in with my little spiel about something I care about.
Thank you, Brandy. That was great. I think maybe I'll just take a quick moment and see if folks, before we kind of start to talk a little bit about maybe how others are collecting SOGI data, and see if there are any questions for Brandy. And I think there might be some in the chat too, Chad, I might have saw.
Yeah, there's one in Q&A and one in chat, which are similar. And Brandy, the question kind of center around at two things. At what point in the process of the patient's encounter is this information typically collected? And are there certain roles or departments that are encouraged to do so maybe more than others?
So I would say, I mean, our system is large, so it's probably collected lots of different ways. I know that I helped the primary care throughout the whole system just add like pronouns and gender identity to their general intake form. They don't have everything on there, but they have a few of these pieces of data just on their patient questionnaire, or whatever they're calling that form. And then like my clinic, we have all of it collected at the start of treatment here, like for our patients. And I know I've helped a couple other departments figure out like just a nice form that has all of it that they can use for people to just check off. So I think that's kind of being piloted a few different places. So there isn't a standard where you collect any of this information. So I think a lot of times folks who have the first encounter with the patient first, they may find out the pronouns and then they'll inform somebody. So there's a lot of passing that on to make sure they get entered.
Brandy, this is Marty. Can you go back to something you said about sexual orientation not being all that useful clinically? I know we have QHCs have to collect that information. We've got categories that we've got to count. What would be more useful clinically in terms of understanding risk for pregnancy, STD, things that have been associated with sexual orientation?
I think if the question is like pregnancy risk, but that should be part of more of a clinical screening about pregnancy and not lumped into sexuality. So I think a big piece of it is it's hard to convince patients why. So like I have to just say like this is just so that we can analyze when we collect everybody's information how at risk is our community. So I need this information from you as a way to help us understand our community, but it doesn't help the patient's actual care. I think it complicates things because a primary care physician may say, oh, I see, they might not screen for something because someone's marked as gay or lesbian. Or they might choose to screen for something because they are, but just because someone identifies as a lesbian doesn't mean that their partner can't get them pregnant. So I think we have to really expand our understanding of people, and we're talking about sexual orientation as an identity as opposed to as some kind of a. It doesn't mean the same for every person, I guess, and so that's why it's not as useful in that like individual patient. For the individual patient's care, you have to ask additional questions. I hope that answered your question. I'm also working on like this very cool inclusive sexual health history project and trying to educate folks on how to ask those questions in the clinic.
That's great. I know, and kind of along those same lines, I saw Wendy put into the chat. So for some of these folks, even if they are just collecting, a couple of data points, is there any scripting or any staff education that you've used or done for those folks, Brandy?
I think like I said, I'm coming at it from a grassroots place and then helping the system down. So, I mean, I think we've come up with different scripting for different people, but there isn't an agreed upon script. But when I train them with this tool, I always demo, and then I demo as this is how I collect this data. So I always demo with an example, not just showing the tool. And I feel like that has been very successful with people talking through scenarios that they encounter in their practice. I've gotten a lot of mental health providers to be really open to using this smart form. Whereas if we first went out, everyone was like, "Oh, that's primary care." So, it's like, no, it's everybody's role. So yeah. I think the scripting changes based on who might be collecting it or why they're choosing to collect it at that moment.
Yeah, I think that makes sense. Great, thanks, Brandy. I guess, and I know we just have maybe just a few more minutes to chat about this, but I wanted to sort of open it up to everybody. I know we talked about previously how you collect the social health data, but if folks maybe want to share if they are collecting SOGI data, how they're doing that. Are they doing that also similar to the social health data? Are the same folks tracking it, or is it different folks? Is it happening, at time of registration for an appointment, or, how folks are going about doing that?
This is Holly. I can start. We have the great fortune actually of having a gender affirming provider at our location. So we have had to, I don't want to say adapt, but change thinking a little bit. And she provided some training for staff. We did change some forms. So we are collecting that data. The front desk staff typically reviews the form. The patient is handed the form, and the provider does take care of a couple of the areas in what we call our patient demographics. I think some of the biggest challenges that we have had comes from the payer side, because the payers don't recognize sometimes if we have unknown for a birth sex, or if the patient, for instance, if a patient gets registered with a name, but it's not their legal name, and the payer has their legal name, they don't match, so that then the insurance doesn't verify it. So that's been some of our bigger challenges, and how trying to get around that and deal with that, and making sure that we have, legal names and that sort of stuff. And the provider that we have has been really helpful in helping us trying to figure out all of that, and how to ask these questions in a manner so that we can get the answers we need.
I can speak to Northern Lights process. We've done a lot of work in this past year with educating on gender identity, gender diversity, how we capture this. We now have preferred name as well as legal name, and it does show up on the patient's wristband if they're inpatient, which was a big step for us, as well as preferred pronouns. So that was a big deal. We are asking this question at registration as well as in different areas, and trying to make sure it does follow through with the patient. We do have birth sex, and if they have an identified gender that conflicts when the patients show up on that patient list, there's like a little asterisk that just kind of notifies a provider that the birth sex is different than the identified. So we did a lot of work. We also did a lot of training with our employees throughout this past year on just gender diversity in general and sexual orientation, to help them understand why these questions are so important and why they do matter. So that was really impactful over this past year. We did have quite a bit of feedback. We also added some questions to our patient experience surveys, asking about how we were doing respecting gender identity and sexuality. And we got a lot of negative feedback from our community about asking those questions, which was surprising to us. So like Emily mentioned earlier, we have a campaign, so to speak, to help our community members understand why we're asking these questions, why they matter, and the impact that it has on their overall health.
And let's see, I think that I can get my mouse to work. All right, Nisha put in, sorry, and then I'll go right to you, Marty. Nisha wrote, PCHC does this through a registration process. A patient fills out the information either electronically through the ClearWave patient portal that they've mentioned previously, or they do it on paper at the office. We have some providers who are wonderful about having conversation with patients about the information provided, but we do have work to do on our end to educate providers on how to ask relevant questions, follow up. So that is great from the PCHC side of things, and sounds great. Marty, go ahead.
So yeah, we do things similarly to PCHC. What's a little confusing with the HRSA, that our health centers are funded by HRSA, the Health Resources and Services Administration, and the HRSA questions, the HRSA's categories are for gender identity are, the obvious ones plus unknown, don't know, and choose not to disclose. And the paper form just doesn't explain what any of that means. So, a parent will determine, my 3-year-old absolutely is a heterosexual male, as opposed to don't know. But anyway, we had a fairly pragmatic approach, fill out the paper form and on an annual basis and update our system. And I think we could probably improve things and we could use some help with that. But so Brandy and Anne, if you have thoughts on both staff training as well as some just process improvements, I think you'd find a willing audience here.
That's great. Thanks, Brody. And Wendy, is there anything on the Maine General side that you want to add?
Sure. So at Maine General, there's definitely opportunity here. And I think this is a great conversation to have because it sort of, brought to light the fact like our patient registration forms, aren't really addressing this. When our ambulatory patients are checking in, they are asked the question, as a new patient, sex at birth. And sometimes patients will then, provide additional information, which, then is captured in sort of gender identity. Oftentimes, though, it's sort of the conversation that's happening between the clinician and the patient, in the room. And so that data is being captured, in a non-structured way. Sometimes some of the clinicians will ask the front office staff to go back in to the registration system and add that information. We do have a spot for preferred name that is used typically for our transgender patients. One of the things that came up not too long ago was we did have a complaint on the inpatient side. And so we moved sort of the male and female, sex at birth from the wristbands for our inpatients. So we're inching along, but I think it's a great conversation to be having and to learn from others in terms of, what's happening in other systems. We definitely, because a lot of that information is collected at the time of sort of check-in, there's a lot of, that's why I asked the question about scripting, because there's a lot of concerns about the fact that the patient's sort of standing at an open window, with the waiting room behind them. And is that an appropriate time? How are those questions being asked? So certainly, love to hear more from this group and kind of learn from your experience.
I think that's great. And something that's just really important to think about, right? I mean, to me, oftentimes everything is about delivery. It's how you deliver that information. It's how you ask that question, how you respond to that. What is your approach and your delivery about things? So certainly, and we all know so many people touch a patient, an individual, right, when they're getting healthcare. And so it's meeting that person at the most appropriate time to be able to have some of these conversations that respect privacy too at the same time are really important to think about. But this is a really great conversation. I'm really excited about it and really appreciate Brandy and her presentation as well. Chad, I think we had a poll question that we did want to present to folks in the audience.
Let me grab it. Okay, so it's similar to the first one. Launch it. So the question is this again for attendees, is your organization currently collecting sexual orientation and gender identity information during patient encounters? So we'll leave this up for a few seconds and then share the results. All right, movement seemed to have stalled. So let me end the poll, share the poll. All right, so 67% of those that responded say that yes, they are being shared and collected in some form, and 33% no, not yet. Super, thanks for sharing that with us. And Nicole, we have a couple of questions in the Q&A, and I think, Brandy, they are for you. So let's see, let's do this one first. So Brandy, how are changes to SOGI data elements tracked over time? And the example is, so if a patient changes their sexual orientation and or gender identity over time, are those changes stored in your system? And is there any relevance to those historical changes, or is it really just the most recent values that are of interest in a clinical setting?
Good question. I'm sure there's a way to go back and find, I know there's a way to go back because I've had to go back and find out who entered certain data. So I know that that could be tracked if you needed to. I don't think this is the way we have it built as a smart form. So it just updates. So it's always today's information is always what you see. But I'm sure there's a way to go back, but it's not presented clinically as in this was updated on this date. It could be changed really in real time at any time. So a patient could change their information in my chart and then a provider could then update it. I have, our staff will enter it from paperwork and then I'll have a conversation and then often we'll update what the patient, maybe just put on the paper last week, but now we're having a conversation and they want to provide more accurate information. So I think that fields change all the time. It would be really hard to have a tracking, at least in my clinic, right? I mean, I'm working with, 2000 gender diverse people. So it's in my opinion, that would be really hard to constantly track gender identity changes in particular.
And so
but the data could be pulled in at any moment into the note, like the current data could be pulled into a provider's note at any time they need to capture like today's decision making.
And every time they're coming to you, Brandy, do you ask the same questions, or is there a frequency to which maybe folks are given the opportunity to update if they wanted to, in a way that's a prompted one rather than maybe them sharing it themselves?
Yeah, I don't think there's an agreed upon how often you should be updating. And I think it depends on the field. So I don't know that it would be appropriate to ask everyone every 3 months, is your gender identity still male? And then 3 months later, so I think giving people an option of, this can be updated at any time. And I don't really know where this is going to live in the future in terms of, we've had questions from pediatrics and adults, and when do you, my goal is 100% completion for every patient, knowing that it can always be changed, because you could fill this out for a newborn in about 30 seconds, because you just say you don't know. You have a don't know, we hit an autofill button and then we move on, and then that can be updated at any future point. So a lot of variation.
Yeah. Chad, were there other questions?
I think that hit on a couple of the other ones that were in there.
Okay.
I have a question though, and this goes for whether it's SDOH or SOGI data, because I think we're like in the general Q&A phase now. I'm curious if the information you're collecting about social risks, needs, or SOGI data elements are paired alongside the clinical records. So like Brandy, I noticed, obviously you click a button, there's the sheet, right, with all of their information. So it does look like it's paired with it pretty closely. I'm just wondering if there's any system barriers that kind of parse the data, and if some folks may not have access to everything, like are there any like consent or privacy seals that need to be broken in order to access these various pieces of data? That's, I guess, for anyone.
I know it sounded like, Emily, your example with Acadia before, that there was some barrier to which maybe folks were having access to certain data or wasn't going to different like organizations. Sorry.
So yeah, that was just from a behavioral health perspective.
Okay.
From their data.
Okay.
Yeah. So I
So
think
they were collecting it. It was sort of shielded as far as what was system wide.
Yes.
Okay.
Yes.
Okay.
In NextGen, it's both in practice management under the demographic data tabs and as well as in the medical record under confidential medical information, which is also where substance use and history of incarceration, the other social risk factors and SOGI data mostly appear.
So our smart form is not a protected field. It's not a confidential field. So anyone who has a clinical access in the health record has access to that form. And then anyone who's in the registration has access to the registration component. So they can't see the rest of the form, but they can see the fields that have been filled out that are in registration, and the patient can see what's in the patient portal. So we have a nice disclaimer. You know, this is now part of your legal health record. And so I do work with providers on how you can document in a systematic way in our record, if this is just between you and the patient, and then what do they want part of to be represented in their health record for identity questions.
And Holly, I don't mean to put you on the spot. I'm just curious if your experience with NextGen is the same as Marty, where it is under that confidential tab or folder.
Yes, it is the same.
Yeah, so that's interesting. And this is kind of getting at why we're doing this, is because we're learning from all of you in terms of how do we manage that data within our systems, for example. And one thing that I've heard is HIPAA doesn't provide real great guidance with what to do with social health or SOGI data like it does the medical side. And so, Marty, Holly, Brandy, it's kind of a mixed approach, right, is what I'm hearing. And is that an organizational / EHR policy? Do you know where those decisions are coming from, to say put it behind a separate wall, or maybe to include it more tightly?
I don't know, but I suspect it's a system decision that's sort of beyond us. I think that's what we get.
Yeah, I don't think we had choices.
Yeah.
So
I think ours was part of the EHR. So when Epic brought this, that's how it was built for us, or it was built and we could take it or leave it. And so we actually debated taking it or leaving it in both 2018 and 19 in terms of, was the system ready for this form? But yeah, I don't think we got to choose.
I'm not sorry, Nicole, I'm kind of stealing your Q&A. So on top of that, so you think of community information exchange, one of the things that often comes up is lead with the community or the social setting and not the medical setting, right? Start with kind of the folks that aren't always at the table. And so hearing that the EHRs are kind of maybe delegating how things are approached with SDOH and SOGI within your organizations, do you see that as a current? Do you see that as a barrier, or has it worked so far for you?
I can say for Northern Light, it was certainly a barrier. We had a lot of limitations when we started tackling this a year or so ago, but we got through it. So it was good, but there's a lot of places that just aren't doing this yet. And so, but they're getting their requests a lot. So we were lucky that we were able to, have our voice heard and say what we wanted. And they were, quick to accommodate, but it did take time. And there are always limitations for you can have this or that, but we wanted this one, but we couldn't have, you really can't always make it your own. So that certainly does have challenges with the limitations that they all have as we're evolving.
And I think just to add along to that, Tamia, is that we're a lot of the beta testing sites for Cerner around this information. So in regards to what I talked about before, the patient risk scoring, we're going to be the first system utilized within Cerner to use this product. So this is all very new. So we're really excited that we're able to partner with them to be beta partners on some of these things that will be rolling out. So I think there's just more to come, Chad. I think it'll be interesting to see, what actually does go live. What can we implement? What can we help change? What can we help make it better? And so really looking forward to that piece as well.
Yeah, that's great.
yeah, I agree with Emily too. I think we all have to do due diligence to really sometimes push the EHR vendors in the way that we feel that it would be best. And that does obviously becomes a challenge, right? Because, but I think that as organizations, we have to continue to push them to give the best product as things evolve in the healthcare arena. I have a question for Northern Light and Maine Health. If you agree to this form, this smart form or whatever that you're using, is it for all of the Maine Health within the Maine Health system and the Northern Light? So like individual hospitals don't have their choice either. Is that correct?
That's correct for Northern Light. Yes, so there's a lot of internal debate before we can, pull that trigger, because it is for all.
Yeah, we had we have a unified health record as well. I think I found that it has been helpful when I went back and found out how Epic made their decisions, even about the fields that I did not like, was very upset about and had us remove at the time, and kind of went back. I met with folks at Epic. Previously, I'd met with folks at Meditech when I was trying to make that record more functional for us. And, it's helpful when you understand why they made decisions. And so Epic did partner with Fenway Health for part of their questions, not the offensive ones, but for a lot of it. So I did feel more confident that they were pulling from some best practices. And, Fenway kind of leads, community LGBTQ healthcare. So I felt better moving forward, but when we made the decision to move forward.
Great. All right, so we have about now 3 minutes left. So I just want to take a minute here and thank every one of our presenters here on the call who has shared all of this wonderful and great information. I think this is just the start. I think we just sort of touched here at the very beginning of more conversation and more dialogue, especially around data collection. I do want to put in a plug. I'm going to pop up our slide here for our next deep dive. So the next deep dive in the series here is our social health data exchange capabilities. So that is happening 2 weeks from now on February 15th from 12 to 2. So you can see, obviously, there's a little bit of a different target audience as we start to dig a little deeper into a lot of what we've already shared today around the collection methods, but thinking about the different exchange capabilities and how this information gets stored in an EHR. Who else are you sharing this information within your EHR and so on. So a little bit more of a technical conversation in this next deep dive, but I wanted to put in a plug for that. So for those folks that haven't registered and are interested in that deep dive, we will definitely be putting that information out there for folks. And we'll make that link to register available for you. Chad, am I missing anything else to highlight here in these last 2 minutes?
I think you nailed it. Yeah, and the only other thing is we will send a package to attendees. And sorry, Nicole, I was multitasking. If you didn't mention this, the same survey that the presenters were allowed to fill out with the questions that we went over today, the attendees could also fill out from their organization's perspective to inform our final report. So I think that covers it.
Excellent. So one thing I did forget to mention, so this was recorded. So today's session is recorded. And as we've mentioned previously, as Chad has said previously, that there will be a report. You're going to take in all of this information that we get from each of these deep dives and put a report together. So all of that information will be available for folks once we close up these convenings. But again, thank you everyone for attending. Thank you to these wonderful presenters and everything that they shared, and for taking 2 hours out of your day to be a part of this with us. So thank you so much. And we look forward to seeing some folks in a couple of weeks from now. Have a great rest of your day. Thanks.